Okay. If you look at this lady here, the question is what's happened over 20 years. I think all of us, if we're in a gravitational perspective, we can clearly see the brows have fallen, the skin is hanging, the cheeks are sagging, the jawline is hanging. But I challenge you and have you look at that very carefully. Besides the skin changes, if you really look at the brow itself has really not come down. Do we have a laser pointer? Oh, sorry. Is it this? If you look at the distance from the brow to the ciliary margin, it is the same on both sides. Look very carefully. This is a relatively standardized photograph. The skin here has come down a little bit, but if you look on this side, the skin has actually gone up a little bit. So if there isn't a significant gravitational component to the area that looks so significantly gravitational, what is it? Well, look carefully. It's an extremely exposed bony rim. And so the question is a brow lift indicated in her? Maybe. But the goal, I think, in majority of people looking at this now with this new paradigm is that it really is a question of deflation. And even her jawline has actually gone up with aging due to the shrinking of the mandible on the bone. Let's take a look at a more compressed time frame, about 5 years. If you look at her now with this model, instead of looking at ptosis or gravity, you can begin to see there's just more skeletonization going on over a very short time frame. And if you look very carefully at the early 30s, there's already early skeletonization occurring in her. And that 5-year time gap is significant because you reach, to quote another Malcolm Gladwell book, the tipping point, where you're just tipped over to the point where you quote unquote wake up one day and you see a change that you don't like. So a new paradigm that I've liked to use as a method of communication with prospective patients is that the aging process is like a glass of water emptying. So when people ask me, what goes on? Well, if you think about it, we're going to talk more specifically, is that when we age, we go from maybe too much baby fat in youth to an ideal, and oftentimes that's not necessarily in the early 20s for many women who are afraid to look fat, but maybe in the early 30s or so, and then you progressively just hollow over time. So with that model, we can communicate with our patients effectively that we don't want to fill too much fat or make it too full, but we fill it just to the right amount. And as we get older, we just need to fill more. So if you're in your 30s or 40s here, maybe 50s or 60s here, and people ask me, is it permanent? And the answer is yes. When the graft has blood supply, which we'll talk about, it takes. But then you get older, and you just progressively empty a little bit more water over time. We just fill up the water to the point where you look good at a certain age bracket, and then you just lose a little bit more over time. Let's talk about general shapes. You heard Mark talk about blink. How do we judge someone from 20 feet away, their age? And it's because of overall facial shape. So in youth, with a lot of baby fat, we have a certain round configuration that persists into our teenage years. Even a very, very thin, athletic individual has a relatively circular face, and that also persists into the early 20s. And there's these slight changes that occur as you see a transition point in the mid-20s to a more of a triangulation where the buccal zone is starting to come in a little bit, but not significantly. And then when we get into our late 20s, there's a little bit more sculpting, but still a relatively full configured face. And then, as I said, a lot of women like a little bit more sculpted look, and you get this early to mid-30s where there's this beginning to shift into this, away from the buccal and lower lateral mandible into the central cheek and the chin. And then there's this masculinization process, whereas that tipping point occurs by the late 30s, and you just look at it, it looks slightly tired, and then there's more predominance of the outer jawline, and as the malar ligament starts to depress in and you start seeing that line, you start to have more of your cheekbone exposed, which then gives you a squaring off of the face. As you continue with the aging, you start to have ongoing squaring effect where now the lower face starts to dominate. Some of the metabolic slow down and you start getting lower face dominance. It starts to invert the triangle. And obviously with significant periorbital advanced aging in the 60s and beyond, you start to get lower face dominance. So what we've talked about is trying to invert that heart shape into a heart-shaped face and bringing the attention back to the eyes. And you heard Mark talk about framing the eye. I think the thing that I've been looking at now I want to talk about is thinking of the face more as an oval. And that buccal zone is so important to think about. So creating ovals, designing facial balance. I'm going to talk to you about different strategies for different faces and how I approach a face. This is a lady, if you look at her, she's had a brow lift and facelift. Still, you know, she's still very attractive, but her cheekbones are very, very strong. So her buccal zone and her anterior cheek were ways for me to actually ovalize the face and create more of fewer transition points. If I had just given her a larger cheekbone, it would not have given her a very nice look. This is a lady that has a stronger outer face. This is a little bit of upper eyelid, some plasma skin resurfacing, and a fat transfer. And if you look at her, you can see that I've brought the attention back into the central face, away from the buccal zone and the lateral mandible, which are heavier. You heard a little bit about light. I want to sort of talk about how light interacts with the face in an everyday setting. And fat grafting is almost like putting a spotlight on the face. And it's an amazing change because how do we see people like this? You know, this is obviously how most patients see themselves because they look closely at the mirror. They're always saying they have bad lighting, but if you think about it, we always have bad lighting. It's almost always top down, right? Think about it. If you're outdoors, it's top down. If you're indoors, it's top down, unless you're in a Neiman Marcus dressing room where you have diffused lighting, or, you know, my patients say, you know, at 8 p.m. in front of the mirror at certain times it looks good. Well, that's a very exclusionary perspective on lighting. So what's going on? If you think about it from a deflation perspective, if the face is deflated, it accentuates shadows just by creating a light reflex. And if you think about the light being top down, then the more volumetric convexity you create on certain areas, the more light you're shining on it, just by virtue of natural lighting, no matter almost in any condition. Even in that photograph you saw with the two twins having the bounce of flash off them, still creates a better highlight to shadow reflex. So think about that as how light interacts with them. And I can see my patients 20 feet away coming through my door looking very, very, very good, without even recognizing which patient it is, because of the way the light is interacting with them at a great distance. Obviously there's an extreme, but the idea is that the more we pull, the more we can potentially accentuate hollows. And what we want to do is blend that in by filling it in. And what I say to create success in a full face fat transfer is not necessarily if a patient comes in and is extremely dogmatic about just filling one little area. I generally will refuse that patient. And the reason is that everything banks on that one success. If I don't get a perfect lower eyelid fill or perfect cheek fill, or my fat take in one area is 75% and one area is 65%, the cumulative damage is I get a failure. But if I get what I call the 5% rule, which means if I can make the brow pretty good, I can make the lower eyelids pretty good, I can make the anterior cheek pretty good, I can make the lateral subzygomatic fill pretty good, I can make the central buccal area pretty good, I can make the lateral zygomatic fill pretty good, I can make the pre-jowl pretty good, I can make the canine fossa decently well, and the pre-jowl pretty well. My success is that there's a tipping point the other way, that they just see, wow, it looks good. So you need to educate your patients that we're not trying to shoot for a perfect lower eyelid or perfect cheek. We're looking for an improved face by putting it all together and understanding that concept. So I'm going to finish with this concept, is how I